Today we are going to discuss about your topic on the sprint trial. So, may I ask, sir, what was the need for conducting such a clinical trial with such a huge population?
You know that hypertension is very much prevalent among the adult population. Up to 20 to 30% of patients at the age of 60 years, they are suffering from hypertension, which has got morbidity as well as the increased mortality in the terms of cardiovascular events, increased cerebrovascular event, peripheral artery disease, and cardiac failure in future. So people were trying to look at what should be our target of blood pressure control, thereby prevent this end organ damage or mortality reduction. So they thought that we have been monitoring this blood pressure according to JNC guideline 8, keeping BP around 140 systolic. But from various previous trial, it has been understood the mortality data were not coming down. So it was thought that why not to reduce blood pressure further. So it was done in a very systematic manner. They included the patient who were beyond the age of 50, more so 75 years, although they did not include diabetic patient, and they included those patients who were already taking high antihypertensive with some additional risk factor, and they divided two groups. One group was aimed to keep the blood pressure around 120 mm systolic, another was to keep around 135, 134 mm of systolic blood pressure. At the end of 3.5 years, they found out that cardiovascular event and cardiovascular mortality and all-cause mortality was much less when the blood pressure was targeted to 120 systolic. It was more definitely in the patient who were on standard therapy. So it is called aggressive therapy as well as intensive standard therapy. So if we go by the data sprint trial, it has been learned that from the 8,000 patient trial, this particular level of blood pressure, if it is kept around 120 systolic, long term and short term benefits are more. So this was concluded out of this sprint trial.
Right, sir. Do you see, sir, these results are applicable to the general population in the country?
Yeah, this is a very important question which you asked. And now when we just remember the JNC guideline 8 JNC 8 guideline, there is definitely mismatch. Why? Because at the 120 mm systolic blood pressure, few patients can get hypotensive episode or hypotensive symptom, giddiness. Sometimes they may feel hypotensive fall and they may sustain injury also. Second, in this particular trial, one thing is very interesting. 120 mm systolic blood pressure, when it came to notice, then we must see how the blood pressure was recorded. In these cases, blood pressure was recorded, the patient was left alone in a room and there was automated recording of the blood pressure. So maybe even in any given trial, if you record blood pressure like this, there will be difference of 10 to 15 mm. So maybe what they have recorded 120 mm systolic here was actually our clinic record of 130/40 also. So maybe they are possibly overemphasizing. But the learning is that we always should record blood pressure in the quiet atmosphere for the patient. Now how to apply general? In general, some people said that this data of the particularly sprint trial are a bit overemphasized. Like they said heart failure incidence is less, but they had up-titrated use of diuretic. So that may be heart failure incidence is not less, heart failure symptoms are less. So it cannot be applied generally. Number 3, sometimes CKD patients which were taken in, they also didn't have the uniform result. So general applicability possibly will be, still needs to be understood, but it can be definitely applied to the all patients who are above the age of 75, hypertensive with high risk group and hypertensive with the CKD group. There it can be definitely applied.
Right, sir. You are talking about the JNC 8 guideline, where you see, sir, JNC 7 still it was much stricter blood pressure control,
Yes.
but there was a relaxation in the JNC 8, and this study came after JNC 8.
Yes.
So how do you see the clinical extrapolation?
The sprint investigator says there was no study available at that time. So whatever was available, they possibly made the criteria of the blood pressure control to that. That's why it is not even called JNC 8 recommendation. It is called JNC 8 proposal, something like that. So it is not even recommendation.
Right.
So that's why, and people when it came, BP should be kept around 150, 80 in age beyond 50, the age beyond 60.
Right.
People were also a bit anxious. Why to keep higher blood pressure?
Right.
So that recommendation or whatever you can call was also not very easily accepted.
Right. And sir, how do you see for the Indian physicians, Indian doctors, cardiologists? when they are practicing, do they follow this kind of stringent?
I think we should learn from everything whatever has been observed. Number one, whenever patient come to us, we should discover what are optimal level of blood pressure with the patient. Number two, we should also tell them that we are recording your blood pressure, trying to keep yourself calm, cool, composed, and then we'll record blood pressure. So then we'll give you the exact reading of blood pressure. Number three, then we should also tell them proper adherence to the drug. Number four, we should also warn them that if you don't control your blood pressure, you can get target organ damage also.
Right.
And they should be made aware about the possible side effects so they can report back to you. And they should have periodic checkup for the all target organ damage.
Right.
And number four, pill burden. Well, it is always said, but most of the trials have shown if you have to have adequate BP control, you may possibly end up in using 2 to 2.5 drugs per patient per day.
Right.
So that you have to explain to the patient and they will accept.
Right. And sir,
Indian patient may need little more education.
Right.
Indian patient may need more, you have to make them more cooperative.
Right.
And drug cost is, I don't think there's very expensive drug as far as the BP drugs are concerned.
Right.
So that is not a major issue.
Absolutely. And sir, regarding the blood pressure monitoring, the ambulatory blood pressure monitoring was used in sprint trial.
Yes.
So do you see that is the practical approach in your clinical practice?
Yes, very much. It's very important, interesting, and nowadays most of the physicians are trying to use ambulatory BP monitoring for a couple of reasons. Number one, to know what are day-to-day fluctuation. Number two, whether there is a night dipping of blood pressure or excessive dipping.
Right.
And then what happens during his excitation or workplace blood pressure fluctuation. Thereby you can put your drugs on right timing and select the drugs in right timing. And ambulatory BP monitoring nowadays increasing as far as the awareness is concerned among Indian physicians, but however it is very well accepted now.
Right, sir. And sir, if I ask you, what is your personal opinion? I mean, what do you learn from this sprint and how do you interpret and in your practice?
The learning never stops, number one. So many people who were not feeling with the results of sprint trial comfortable. So there is another trial which is coming up. That is known as that is European Society of Hypertension with Chinese Society of Hypertension. And what they are doing, they have been observing with the same risk factor, previous stroke, cardiac problem, and they put 3 systolic blood pressure guidelines, 3 groups.
Okay.
One up to 135, second 125, 140, 130 and 120.
Okay.
And this data will be available maybe in next year. So then we'll learn more which are more safe to prevent further recurrence of the stroke and cardiovascular event. So that is what we are looking at. Till then, possibly we'll keep our patient's blood pressure around 130 plus minus.
So what would be your concluding remark on your talk and on this topic, sir?
I would say sprint study was designed very well. They included high risk patient basically. They tried to impress upon all the observers that if we take care of the good blood pressure control, cardiovascular mortality and all cause mortality comes down. However, recording of blood pressure in that trial, whatever was done, was ideal one, and we should also adapt to the ideal one.
Right.
And we can always monitor data more frequently, and thereby we can apply to the patient.
Right, sir. Thank you very much, sir. Conducting such a clinical trial with such a huge population.
You know that hypertension is very much prevalent among the adult population. Up to 20 to 30% of patients at the age of 60